I am Leema Rosemary, Assistant Professor, Department of Biochemistry, St. Joseph College of Arts and Science, Cuddalore. Now I am going to talk about oral antidiabetic drugs. Oral antidiabetic drugs used for the diabetic patients. These drugs otherwise known as oral hypoglycemic agents. Oral hypoglycemic agents are a group of drugs used to help reduce the amount of sugar present in the blood. They are not insulin, but they stimulate the pancreas to produce insulin. They are usually used in the treatment of adult onset diabetes, that is type 2 diabetes, otherwise known as non-insulin dependent diabetes. The early sulfonamide tested in 1940s produced hypoglycemia as a side effect. The first clinically acceptable sulfonylurea tolbutamide was introduced in 1957. Clinically useful bicarbonate fenformin was developed parallel to sulfonylureas in 1957. In the 1970s, many second-generation drugs, sulfonylureas, have been developed which are 20 to 100 times more potent. Recently, three newer classes of drugs, that is glucosidase inhibitors, meglitine analogues, and thiazolidinediones, have been inducted. These are the classification of oral hypoglycemic drugs. Sulfonylureas, there are two types, first generation drugs and second generation drugs. First generation drugs include tolbutamide, chloropromamides. Then second generation drugs are glimenclamide, glimpizide, glycoside, climpride. Bicarbonate, example metformin. Then meglitine or phenylalanine analog, example ribaglenide, netaglenide. Then thiazolidinediones, example rosiglitazone, pioglitazone. Then alpha glucosidase inhibitor, agarbosmiglytol. These are the drugs used for the diabetic patients. First of all, sulfonylureas. This most commonly used drug. This is the structure of sulfonylurea. Sulfonylureas are chemically related to sulfonamides. These agents promote the release of insulin from beta cells. Example, dolbutamide, glimepiride, glimpizide. These drugs lower the blood sugar level on oral and parenteral administration. They lower blood sugar level in some of the diabetic and in all non-diabetic individuals. Sulfonylureas are effective only in presence of functional pancreas. Mechanism of action. Sulfonylureas act by the following mechanism. It provokes a brisk release of insulin from pancreas. They act on sulfonylurea receptors on the pancreatic beta cell membrane, cause depolarization by reducing conduction of ATP sensitive potassium channels. This enhances the calcium influx which promote insulin secretion. It also reduces glucagon secretion and increase the binding of insulin, increase the number of insulin receptors. This is the mechanism. This is the sulfonylureas receptor. Here sulfonylureas bind with sulfonylureas receptor. Here the membrane cause depolarization by reducing conduction of ATP sensitive K+ channels. Then the calcium ions enter into the pancreatic beta cells from outside to inside. Then it induces the or promote the insulin release. This reduce the blood sugar level. This is the mechanism of sulfonylureas. Then pharmacokinetics. All sulfonylureas are well absorbed orally. and 90% are more bound to plasma proteins. They are metabolized in liver and excreted in urine. It's rapidly absorbed from GI tract. The adverse reactions are hypoglycemia and allergic reactions leading to skin rashes, bone marrow changes like leukopenia and thrombocytopenia, then hypothyroidism and goiter. The non-specific side effects are nausea, vomiting, flatulence, diarrhea or constipation, headache and weight gain. Dosage form: dolbutamide tablet 0.5 to 1 gram per day, chlorpropamide tablet 250 to 500 mg per day, glibenclamide 5 mg 2 times daily, Glimpizide 5 mg once a day taken with breakfast, gliclazide the usual dose is 80 to 160 mg daily, glimepiride 1 to 6 milligrams once a day. Therapeutic uses are it mainly used for the type 2 diabetes mellitus, that is maturity onset diabetes mellitus, and it resistance diabetes insipidus. Then biguanides. Two biguanides anti-diabetic drugs are used, that is penformin and metformin. This introduced in the year 1950s because of the higher risk of lactic acidosis, and the penformin was withdrawn in many countries and has been banned in India since 2003. The pharmacological actions of biguanides are lower the blood sugar level only in a diabetic individual but not in a normal individual. They potentiate the hypoglycemia action of insulin and sulfonylurease. They inhibit lipogenesis in adipose tissues and also increase fibrinolytic activity of plasma. Mechanism of action: biguanides do not cause insulin release, but presence of some insulin is essential for their action. So it suppresses the hepatic gluconeogenesis and glucose output from liver. It also enhances insulin mediated glucose disposal in muscle and fat, retard intestinal absorption of glucose, other hexose, amino acids and vitamin B12. It interferes with mitochondrial respiration chain, promote peripheral glucose utilization by enhancing anaerobic glycolysis. However, metformin binds less to mitochondrial membrane. This is the mechanism. Here metformin in liver, it reduce or suppress the gluconeogenesis. Gluconeogenesis means glucose synthesized from non-carbohydrate compound. So that process suppressed, and also suppress glycogenolysis, that is breakdown of glycogen, and oxidation of fatty acid. These three processes suppressed by metformin. In skeletal muscles, it increases the insulin mediated glucose uptake and also increase glycogenesis, that is glucose synthesized from glycogen synthesized from glucose. These two steps these two reactions increased, and at the same time the fatty acid oxidation decreased. Here intestine and the anaerobic glycolysis produce pyruvate to lactate. These three are reduce the blood sugar level. Adverse reaction: unpleasant, bitter or metallic taste, abdominal discomfort, anorexia and nausea, lethargy and muscle weakness, decreased in body weight. The dosage: penformin tablet 25 to 150 mg per day, but metformin 500 to 2000 mg per day. Therapeutic uses mainly used obese mild diabetic patients and also non-diabetic obese patients, in patients allergic to sulfonylureas. Thank you.